What do you think, Dr. Jacobs? You ready?
I'm ready.
Let's do it. All right. I'd like to thank everyone today for joining us. Today's presentation is focused on fluoroscopy-guided interventional radiology. My name's Ron Tibbett. I'm the Vice President of North American Sales for Epica Animal Health. For those of you who are not familiar with Epica Animal Health, we manufacture high-definition volumetric imaging platforms that enhance diagnostic accuracy, improve diagnostic confidence, and provide better outcomes. Our company's dedication to innovation and engineering has earned us multiple patents, as well as the trust of well-known research facilities, educational institutions, leading veterinary hospitals, and specialty groups over the last 10 years. There are currently over 350 progressive veterinary hospitals using our imaging platforms and regard high-definition volumetric imaging as the new standard of care. I am joined by Dr. Frédéric Jacobs, diplomat, ACVIM, PhD, practicing at Atlanta Veterinary Internal Medicine in Townsend, Maryland. Dr. Jacob earned his veterinary degree from the University of Montreal in 1995. He interned at Washington State University and carried out his residency and then received his PhD from the University of Minnesota. Dr. Jacobs and his wife, Kristen Jacob, a veterinary cardiologist, have twin sons, an English Labrador, and a Cavalier King Charles Spaniel. When he's not at work, Dr. Jacobs enjoys running, biking, and traveling. Before we get started, I'd like to address a couple of housekeeping items. This talk is pending approval for 1 CE credit. All qualified attendees will receive their certificates within the next few weeks. Number 2, there will be a 5-question survey at the conclusion of the presentation. Your answers are required to earn your race credits. Number 3, this webinar is being recorded. We will provide a link to the recording within the next few days. And lastly, you're more than welcome to submit your questions to the QA box. However, all questions will be addressed at the end of this presentation when the QA session begins. Without further ado, here's Dr. Jacobs.
Thank you, Ron, and thank you everybody for coming and carving a little bit of time out of your, I'm sure, very busy schedule to listen to me talk about fluoroscopy-guided interventional radiology in dogs and cats. So before I begin, for those who are not that familiar with the term interventional radiology, well, it is defined as the use of minimally invasive techniques to deliver specific material to diseased portions of the body. And in my opinion, we can use interventional radiology for treatment purposes, but we also can use it for diagnostic purposes. And in the next slide, I'll give you a quick example of that. We use interventional radiology when medical treatment has failed or surgery is just simply not recommended because of a high risk of morbidity and mortality post-op. Because of its minimally invasive nature, interventional radiology is associated with less post-op pain, faster recovery, and also probably decrease overall cost to the owner. So this is just to give you a quick example of using interventional radiology for diagnosing particular diseases. So this is a 17-year-old female spayed domestic short hair that was presented to her primary care veterinarian because of a history of weight loss as well as occasional coughing. And so chest x-rays were obtained, which showed a pulmonary mass within the pulmonary parenchyma. So the cat was referred to us for thoracic ultrasound and tried to sample that mass. But unfortunately, because of the ultrasound air interface, it was actually not possible with the ultrasound to visualize the soft tissue density. So rather than to go to surgery, at my clinic, we provide a new technique using fluoroscopy for sampling of those deep-seated pulmonary lesions. So this is just an example of to use interventional radiology for diagnostic purposes. And that particular technique, we'll talk a little bit about it more towards the end of the presentation. So I was going to present myself. I didn't know that Ron was going to tell you who I am, but essentially, yes, I'm from Quebec, graduated from the University of Montreal, and my specific interests are primarily urinary tract diseases. And we started in the last 10 years or so. I've been doing more and more interventional radiology, and then also quite a bit of interventional endourology. And then talking about interventional radiology, I think on March 31st, I will be presenting another interventional radiology presentation, talking about urinary issues rather than respiratory issues, as we're going to talk about tonight. So when we hear the term VIMAGO, we always think about this high definition CT scan imaging that it provides. But tonight, which is actually the primary objective of this this presentation, is to increase the awareness of the great capabilities or fluoroscopic and interventional radiology capabilities that this VIMAGO machine also provides, and also to recognize the usefulness of using fluoroscopy for diagnosis and treatment of different respiratory ailments. And then we'll talk about different diseases tonight. We'll talk about nasopharyngeal stenosis. We won't talk about nasopharyngeal collapse, but we certainly can use fluoroscopy to look at the dynamic collapse of the nasopharynx. We'll discuss tracheal collapse as well as deep-seated pulmonary lesions and how we can sample those. All right, so what I was thinking tonight is that we are going to start with the nasal cavity and go down the respiratory tree. We'll talk a little bit about tracheal diseases, and ultimately we'll talk about pulmonary diseases. So this is Kiss, who is this 8-year-old female spayed domestic short hair that was presented to her primary care veterinarian because of a severe upper respiratory stutter for about 6 weeks or so. And interestingly, in her history is that she has had a recent anesthetic event 2 weeks before the development of that stutter. So occasionally she was open mouth breathing, primarily when she was playing. And rhinoscopy had been done at the different specialty clinics, but they could not really visualize the nasopharynx, but thought because they could not really visualize it, was most likely dealing with some form of nasopharyngeal stenosis. So this is a video of Kiss, that little cat that has some upper respiratory stutter, and you can hear it occasionally.
Okay. Come here. Do you want to play with it?
So right there again. So we can hear the stutter that she's having. So most likely something associated with the nasal cavity. So based on, we did a physical exam, obviously. So again, this moderate inspiratory stutter that she was having, decreased nasal airflow on both sides of the nasal cavity, and then no nasal discharge. And the owner also had never mentioned that there was any significant nasal discharge from Kiss. Blood work was unremarkable, and then CBC, so urine analysis also was completely normal. So what we decided to do is we actually decided to do another rhinoscopy to try to figure out a little bit what was going on. So this is a fluoroscopic image of the skull right here. You can see the spine, you can see the esophagus, the endotracheal tube right here, and then you can see the soft palate, and then that's the hard palate. And you can see here the bully of the kitty. And obviously this is the scope that is going through the mouth and looking back at that nasopharynx. And instead of seeing kind of that cavernous region of the nasal cavity, you actually just see that very narrow region, which is that, typical for nasopharyngeal stenosis. So what can cause nasopharyngeal stenosis? We don't know for sure, but we think that it is most likely associated with some form of gastroesophageal reflux or vomiting, which leads to accumulation of gastric content within the nasopharyngeal cavity, causing a chemical rhinitis, inflammation, and ultimately fibrosis. But certainly in cats, especially in cats, certainly can be associated with some form of lymphocytic plasmacytic rhinitis. Could be iatrogenic secondary to soft palate surgery, trauma, and in some cases it also can be congenital. I think in cats and I think also in dogs, but don't quote me on that. But the problem with nasopharyngeal stenosis is because there's really no medical treatment you can do to get rid of that stenosis, right? So you have to use, or you have to think about some form of effacing or effacement type of procedures to try to get rid of that fibrotic tissue. And in cats, certainly ballooning of the nasopharyngeal stenosis is something that can be done. And about 30% of the cats will respond solely to ballooning. So you just do balloon and then you get rid of that stenosis. But that also means that 70% of them will have recurrence of the nasopharyngeal stenosis. So often in cats, when we see them, we always tell owners, well, we can do this ballooning, but you have a very high chance of recurrence, and do recommend stenting also in those patients. In dogs, the nasopharyngeal stenosis is very aggressive, and ballooning by itself is not going to work. So in dogs, we always recommend not only the ballooning, but also nasopharyngeal stenting. So this was a study done by the AMC group in New York, where they looked at 46 dogs and cats that had nasopharyngeal stenosis. And what the study showed, what the results of the study were, is that showed that most of the time the nasopharyngeal stenosis were located proximally or rostrally. So this is a CT scan image of the skull of a dog. You can see the soft palate here, you can see the hard palate, and you can see that little nasopharyngeal stenosis, which is rostral, as opposed to the skiddy right here, where you see the hard palate, the nasopharynx, the soft palate here, and you can see that little nasopharyngeal stenosis back there. So what that study showed also is that most commonly, unfortunately, those nasopharyngeal stenosis were actually perforated, meaning that there is a little hole, just like what we saw for KISS, versus imperforated nasopharyngeal stenosis, which are much more difficult to deal with, to actually, perforate that membrane, place a balloon. So these are very, very complex cases, but fortunately, they are a little bit less common. So what that study showed is that ballooning and stenting for nasopharyngeal stenosis actually had a pretty good success. So 70% success rate for, when we're using uncovered self-expandable metallic stent, and up to 100% success rate in terms of getting rid of that stenosis when you're using covered self-expandable metallic stents. So the only thing that was bothering me a little bit about that study, which is not a big bother, but it was bothering me a little bit, is just the rate of complication. So up to 70% of the cases had some degree of complication, some of them very minor, just infection, sometimes migration, especially for the covered stents, sneezing, some nasal discharge. But there are also some major complications, such as the development of oronasal fistula, and sometimes tissue ingrowth through uncovered metallic stents. So we're a little bit hesitant to use that particular technique for KISS. But we came about a different study, actually 15 cats, and it's difficult to compare the two studies because it was a little bit different, obviously. But in that study, it was only cats, and what they did is they essentially dilated the nasopharyngeal stenosis prior to stent placement. The stent, instead of being a self-expandable metallic stent, was simply a little piece of a chest tube or thoracic tube between 24 and 28 French. And that stent was placed left in place for about 3 to 4 weeks, and then ultimately removed. And the results of the study were actually pretty compelling in the sense that there was resolution of all the clinical signs in all cats, and also resolution of the nasopharyngeal stenosis as proven by endoscopy in all the kitties. And more importantly, I thought, was that actually there was only very minor complications. So some nasal discharge and some sneezing, but no major complications. So that's what we elected to do for KISS, use that particular technique. So this is a quick fluoroscopy movie of the ballooning that we did. So just to give you where we are, so this is obviously the skull right here. You have the bullage right here. You have a balloon that is partially inflated. That's a guide wire that is going through the nasal cavity, down the nasopharynx, and then ultimately down the esophagus. So what we're doing is that we're trying to expand that stenosis right here. But The cat doesn't really like it, but it's actually very difficult to break down that stenosis. So what we ultimately decided to do is use a larger balloon and try to expand that stenosis. So remember that stenosis is about right here. So the balloon is from here to here. So you'll see that we're going to slowly inflate the balloon with some contrast. And you're going to see that stricture that is going to essentially disappear. So the stricture is about right here. And then as the balloon is expanding, we finally are able to break down that stricture right here. So we repeated the procedure 2 or 3 times, and then we looked back with the scope and remember how it was before. And this is after the ballooning. So you have the guide wire right here, and that's the nasopharynx post ballooning. So obviously a little bit of blood that's kind of expected to see after we dilate that region. So with different manipulation, we ultimately were able to place that stent. So this is the piece of the chest tube that we placed in the nasopharynx. So remember that stricture is about in that region, so just under the bullies. And then we left it in place for about 4 weeks. So a week after the procedure, Kiss was actually doing pretty well, according to the owner. Some nasal congestion, some sneezing, and then we had sent her home on Clavamox as well as prednisone for about 8 weeks. So that's Kiss while at home. So no noise. So, and she has a little bit of a pineapple cone right here. And then, so we also rechecked her 1 week after. And the only reason is we want to make sure that she was doing well, but also make sure that that stent was still in place. And it appears to be still in the nasopharynx right here. And then a month after the procedure, so that was the time that, we decided to actually remove that stent. She had been doing well clinically. We did a quick fluoroscopy picture of her nasopharynx again to make sure that that stent was still present in the nasopharyngeal region, and it was. And then what we did is essentially just simply remove that stent. And this and after that we did a quick rhinoscopy to show that yes, there was still a little bit of inflammation, some mucus, but overall that nasopharyngeal stenosis had disappeared. So the goal right now is to recheck her in about a month or so, and then make sure that everything is fine. And as long as she's doing well clinically, then hopefully that will be it for Kiss. So this is the first case. Now I'm going to jump into the second case, which is Brico, who is that 6-year-old male castrated Yorkie that was presented to his primary care veterinarian because the owner had noted that the dog was becoming more and more labor breathing, so dyspneic for about 6 months. But because of warming temperature, the clinical signs actually had been worsening significantly. Throughout this entire medical history, there was absolutely no coughing whatsoever. And then chest x-rays were obtained, or thoracic x-rays were obtained by the primary care veterinarian, which definitely did show some evidence of tracheal collapse. So you can see here the cervical trachea here that is relatively normal or relatively open right here. And that's the intrathoracic trachea right here, which looks relatively normal. And then there was another x-ray that was taken, and then you can see significant collapse of that trachea. So definitely some dynamic collapse of the trachea. But then there was something else in that x-ray. There's also kind of that soft tissue density that you see right here at the thoracic inlet. And the primary care veterinarian thought that actually it was a tracheal tumor that was in the trachea, and that's why Rico was breathing like that. But actually, this is not a tracheal tumor. What it is, for lack of a better term, it's what we call tracheal malformation, which is actually a benign proliferation of cartilage that essentially bulges into the tracheal lumen, causing significant collapse of the trachea. And instead of being a dynamic collapse, it is actually a very static collapse of the trachea. So, and I'll show you some endoscopic picture of that, so to understand a little, or to illustrate a little bit better what it looks like. So ultimately, Brico came to see us, and then on physical exam, very severe inspiratory and expiratory effort, some cyanosis, as well as because of this chronicity in terms of breathing hard, his abdominal musculature actually was very, very developed. So this is Brico and how he's breathing. So you can even see a little bit of cyanosis when he puts his tongue out. So very, very severe inspiratory and expiratory effort, as well as significant cyanosis of the tongue. So before we talk about, how we treated Brico or what we did for Brico, let's talk a little bit about tracheal collapse. And I'm sure everybody's very familiar with tracheal collapse, but what we don't know about tracheal collapse is, how it, why it happens. So we don't know why particular breeds are predisposed to it. But what we know about tracheal collapse, at least the classical form of tracheal collapse, is that there is cartilage ring hypocellularity. There is also loss of matrix of the cartilage, which leads to loss of water. There is a failure of making more new young cartilage. And because of that, then the tracheal rings will become flaccid. But on top of that, as they become flaccid, the trachealis muscle becomes a little bit more stretched, and then the trachealis muscle becomes essentially sags into the lumen, which worsen that collapsing of the trachea. Tracheal malformation is a little bit different. Tracheal malformation is more of an excess proliferation of cartilage arising from the ventral aspect of the trachea. And always associated with, always located in a thoracic inlet. So it is always where we find it. This static collapse of the trachea or tracheal malformation can be associated with, just like for Brico, associated with the more classical or more dynamic type of tracheal collapse. So we like to grade tracheal collapse, but before I show you what's abnormal, let's see what's normal here. So this is a normal trachea. So you see the trachealis muscle right here. These are the tracheal rings. You can see the blood vessels very well because the mucosa of the trachea is very thin. And then in the background, you can see the right bronchus, and this is the left main stem bronchus. So when we're dealing with grade 1 tracheal collapse, it's when 25% of the lumen of the trachea is collapsed. And in this case, there is a little bit of cartilage collapse, but you can see the trachealis muscle that is widened and sags a little bit in the lumen of the trachea. Grade 2 tracheal collapse when 50% of the lumen is collapsed. Grade 3 when you have 75% of that lumen that is collapsed. And in this case, you can see that there is also severe inflammation of the airways, and there is also collapse of the left and as well as the right main stem bronchus. And then here you see a grade 4 tracheal collapse, which when it is 100% of the trachea that is collapsed. And dogs typically will develop clinical signs, not really at grade 1, but more when they're from grade 2 to grade 4. So that's when they have this honking type of coughing and sometimes even dyspnea in some cases. So these are just some images taken from that particular study that Dr. Wise from AMC New York did not too long ago, comparing dogs with tracheal malformation and also with the dogs with classical tracheal collapse. But this is just to kind of illustrate the difference between those two. So this is a dog with more classical tracheal collapse versus this more kind of static collapse of the trachea that you see with tracheal malformation. We saw that image a little bit before, so the more classical tracheal collapse. This is what I was talking about this, bulging of cartilage tissue from the ventral aspect of the trachea that is essentially obstructing quite a bit of the lumen here. And essentially, dogs can only breathe through this very, very narrow opening of the trachea. Essentially, they're breathing through a straw, and that's why those clinical signs can be very, very severe when we see them. So I won't go really over clinical signs because, everybody knows what a tracheal collapse dog sounds like. The only thing is that I think that dogs with tracheal malformation, they typically don't have that honking sound as much, but they often have more kind of that very severe dyspnea as we see with Brico, as well as cyanosis. In terms of diagnostic approach, I mean, I think based on the clinical history and chest X-rays, I mean, I think we can diagnose the majority of those cases. I know that chest X-rays have been qualified as being relatively inaccurate in terms of diagnosing tracheal collapse because of the dynamic aspect of the tracheal collapse. But I think that if we take multiple X-rays, try to take a different phase of their respiration, I think in most of the cases, you'll be able to diagnose the majority of those dogs with tracheal collapse. So often I take at least 4 X-rays of the chest, including the cervical region. I mean, X-rays I think are important because, first of all, they're cheap, they're readily available. You can also look for other diseases, right? You can look for heart failure, you can look for the evidence of pneumonia, you can look for tumors, you can even look for, bony type of diseases. So X-rays, I think, are very, very important to diagnose, tracheal collapse. When I'm unsure, then I will use the fluoroscopy. Or if I want to look for maybe nasopharyngeal collapse, or I want to look for maybe bronchular collapse, then I will use the fluoroscopy. But the fluoroscopy may be a little bit more expensive, and it's not readily available. So I always come back to those X-rays that I think are very important. And then tracheal bronchoscopy, I have to say I rarely do it for dogs with tracheal collapse because first of all, you have to anesthetize the animal, and some of those dogs are not very anesthetically wise. Sometimes it's not very prudent to anesthetize them. And often I think just with the clinical history and with the fluoroscopy, we tend to have a pretty good idea of what we're dealing with. I will use tracheal bronchoscopy if nothing is working and the dog still continues to cough, or I think that there is maybe something else, then I will use the bronchoscopy, but it's pretty rare that I will use it just for dogs with tracheal collapse. I have to say that I use the bronchoscopy or the tracheal bronchoscopy when I'm going to place a stent to make sure that nothing else is going on. So that's when I use bronchoscopy in those cases. So associated with tracheal collapse, I mean, you definitely can have other region of the airways that can be also affected. You can have dog with nasopharyngeal collapse, laryngeal collapse, bronchular collapse, as well as lower airway disease. This is a little bit of a tangent. I mean, we'll go a little bit away from the tracheal collapse just for like a few minutes. This is actually one of my nurses' dog that she sent me a video over the weekend because the dog, when the dog was breathing, especially during the expiration phase of the respiration, there was something bulging from the thoracic inlet. And I'm just going to show you that. So you can see right here, as the dog is breathing out, you can see that little bulge right here.
It's kind of freaking me out.
And it's freaking them out.
Like this.
So what I told my technician or my nurse is actually to bring the dog in for me to evaluate. And then as the dog was breathing out, we could see that we took an X-ray and we could see actually that there is a cranial portion of the pulmonary lobe, the left pulmonary lobe, that was actually prolapsing or herniating. And this is because the dog had significant lower airway disease as well as some degree of bronchular collapse. So this is just a quick tangent. It's just something very unusual that we don't see very often in clinics. So I just wanted to share that with you. All right, so tracheal collapse, I do treat it, especially dogs with the classical tracheal collapse, right? So I don't think that dogs with the tracheal malformation respond as well to medication. But dogs with classical tracheal collapse, yes, I will definitely treat as much as I can. 80 to 90% of the cases will respond to medication for at least a year or two. So I think that there is a good case to treat them medically first before we even think about placing any type of stent. So what do I use? My favorite treatment is to use fluticasone because there is some inflammatory component to that tracheal collapse. I rarely use prednisone, and the only reason is because prednisone has a lot of side effects, and one of those side effects is actually panting, and I'm trying to avoid dogs with tracheal collapse to actually pant, so that's why I typically use more something like Flovent or fluticasone inhaler. I use quite a bit of antitussive if they are coughing. My two drugs of choice is hydrocodone and low modal, or Hydrocodone and low modal. And sometimes if the cough is recalcitrant, then I will start using other drugs, sometimes in combination. So sometimes I would use low modal and Serenia, or rarely cough that I really cannot control, then I will start using benzonatate. But that's pretty unusual that I would use that. So most of the cases with Hydrocodone plus or minus Serenia, or low modal plus or minus Serenia, I will be able to control that cough. I'm a big proponent of using bronchodilator in those cases. I think that the lower airways also involved in the respiratory issue in dogs with tracheal collapse. So my drug of choice is to use theophylline extended release or sustained release. I rarely use terbutaline because I think that dogs, at least, tend to have a lot of side effects. In terms of doses, I mean, it's very variable where you read in terms of starting dosing in dogs. I use 5 mg per kg to start with, and then I can increase the dose if I think that they're not responding as well. And then sedative, I rarely use any type of sedative, except for dogs that are very, very anxious. I think with the use of Hydrocodone or low modal, you can control quite a bit of their anxiety with that. And then sometimes, if nothing is working, I use antibiotic. And the reason is because, and don't quote me on that, but I'm pretty sure that there was a paper that showed that I think 50% of dogs with tracheal collapse have some degree of infection. So in dogs that are just not responding to the medical treatment, then I use 10 days to 14 days of antibiotic, and to see if it makes a difference. When do I consider tracheal stenting? Well, coughing by itself is not an indication for stenting. However, if medical treatment is failing, the dog especially becomes cyanotic or decreased exercise intolerance, very, very severe inspiratory and expiratory dyspnea, just like we saw with Brico, recurrent ICU visits, needing oxygen supplementation. I think these are all indications for tracheal stenting. But tracheal stenting, in my mind, is kind of a salvage procedure, right? You try everything else and then think about tracheal stenting for those dogs and cats, as you will see. So this was an interesting study from Dr. Weiss, actually from the AMC group, again, looking at 150 dogs with tracheal collapse evaluated over a period of 6 years. And about 75 dogs in that study needed tracheal stent. So not all of them did. Some of them were obviously treated medically. But there was an equal distribution in terms of need of stent between dogs with the classical tracheal collapse versus dogs with tracheal malformation. And this may be a personal opinion here, but I think that dogs with tracheal malformation tended to need a stent quicker than dogs with classical tracheal collapse, which I think respond a little bit better to medical treatment. What is important to tell owners, I think, is that most of the dogs, or close to 60% of the dogs, will only need 1 stent. But based on that study, up to a little bit more than 40% of the dogs actually needed 2 stents, and sometimes even more, because of complications that can arise after the placement of a stent. And we'll go over that in 2 seconds. Survival time in those dogs, so 93% of the dogs were survived during the post-op period, only 7% death. And they live for 2 to 3 years, and sometimes much longer, right? This is just a medium survival time. The survival time was not influenced by the presence of bronchular collapse or the type of collapse. And the reason why I say bronchular collapse is because a few years ago, we thought that actually the presence of bronchular collapse was a contraindication, or almost a contraindication, to actually stent those dogs. But that study actually shows that the bronchular collapse had no effect on survival per se. But the survival was influenced by age. So dogs that were younger than 7 years old tended to survive 3 times longer than dogs that were older than 7 years old. And male castrated dogs tended to survive longer than female spayed dog, for some reason that I don't really understand why. In terms of tracheal complications, tracheal stent complication, about 50% of those dogs in that particular study had some degree of complication, some of them very minor, but some of them major, such as tissue ingrowth or what we call inflammatory tissue. So this is the stent, a lot of mucus around the stent, but you can see that proliferation of tissue, which sometimes can be so severe that it obstructs the airway. So when we see that, most of the time, it will respond to antibiotic, it will respond to high doses of prednisone, but sometimes it does not, or sometimes it is so severe that actually you have to stent the stent or restent the trachea because of the proliferative tissue. This is a chest x-ray of a dog with a tracheal stent that is actually fractured. And in this case, is what happens often is because of the constant coughing that the dog will do, it will ultimately lead to metal fatigue, and that metal fatigue will ultimately lead to that fracture of the stent. Something that we can repair, we can put another stent through that stent, obviously, but these are kind of major complications that people or clients need to be aware before we place those particular stents. So we come back to Brico. Brico, remember, was this dog that had very, very severe inspiratory and expiratory effort. So because of the severity of his condition, we didn't think that he would respond to any type of medical treatment. So we just went ahead and actually thought about placing a stent for him. So that's what we did. So this is a fluoroscopic picture of his trachea. So he had the endotracheal tube right here. We are measuring the diameter of the trachea, and we're measuring the length of the trachea, and we choose a stent that will fit him the best. So we know that because we see the larynx right here, we don't want to expand the stent further than that. This is a endoscopic picture of his trachea. So that's what I was talking about, that tracheal malformation, which is very, very severe for him. As you can see, his trachea is completely collapsed. He only can breathe through those two little holes that you can see right there. And then past that tracheal malformation, the trachea looks a little bit more normal. Still some collapse, grade 1 type of collapse, but definitely more normal than proximal to that trachea. So just a quick movie of looking at that tracheal stent deployment. So you remember that tracheal malformation is kind of in that region. So we're deploying the stent in that region. But what I want to show you here is you remember that tracheal malformation is a very sturdy structure. So sometimes when you place that stent, the stent actually will not be able to push that tracheal malformation completely out of the way. So, and then the stent essentially sits on top of that tracheal malformation, which creates a little bit of a gap, or what we call gutters. And those gutters will cause accumulation of mucus under the stent or between the stent and the tracheal wall. That mucus will lead to inflammation, will lead to coughing, will lead to formation of granulation tissue or even fracture of the stent. So it is very, very important when we see those little gaps to actually try to do something about it. And that's what we do. So essentially what we do when we see those gaps is that we take this the endotracheal tube, and then we dilate that tracheal stent. And it's a little bit difficult to see, but when you look around here, you can see that we are expanding that stent. And because we're expanding that stent, the stent is shortening a little bit. So right here. So we're trying to oppose the tracheal stent to the wall of the trachea. So, and we do that pretty much where we see a tiny gap. All right, and this is post-stent placement. So we have the stent right here. We have the endotracheal tube right here. So that was before the stenting. This is after the stenting. So it's definitely much more open. And then we always do a quick bronchoscopy post-stent placement to make sure that everything looks okay. So these are the proximal aspect of the tracheal stent right here. And then we're going more towards the thoracic inlet. And you remember how close it was or how collapsed it was, and now how much more open it is. And then when we look for any gutters, there is nothing that I can really see here that looks like any gap between the stent and the tracheal wall. So we're pretty happy with that placement. So we took an X-ray 1 week after, after the placement of that stent. So we can see the stent that actually looks pretty good. It's right behind the larynx. So again, we don't want to open it in the larynx, but the trachea was collapsing right in the cervical region. So we want to cover that as well as that tracheal malformation that was in that region. And then this is Brico after 1 week after we placed the stent.
Brico. That?
I think he is now.
Yeah. Can you pant a little bit? Come on. Yeah. Oh, what you doing?
So Rico seems to be doing pretty well right now. So we are supposed to recheck him in about a month or so, and then we'll see how he's doing from then. So we recheck them in a month, and then every 3 months, as long as they are doing well. All right. So this is a little bit of an unusual case. So this is Stoli, this 1-year-old female intact domestic short hair that was presented to her primary care veterinarian initially for difficulty breathing since the owner adopted the cat. And actually the owner, I think, found the cat somewhere and adopted the cat. The cat had significant exercise intolerance, could not play at all, coughing almost constantly, very raspy noises when she was breathing, severe inspiratory and expiratory efforts. And then, for some reason, the clinical signs were getting worse and worse. She had been treated with antibiotics. She had been treated with steroids, but absolutely no improvement whatsoever with the clinical signs. So she was ultimately presented to the ER to our ER in Maryland with very, very severe dyspnea, to the point that actually she had a cardiac arrest. She had to be resuscitated and then ultimately placed in an oxygen cage. And when we saw her, she was oxygen dependent and still breathing relatively with difficulty in that oxygen cage. So we could not do a lot of diagnostics, but we at least took some X-rays of the chest and the cervical trachea. And then what we saw is that we can see here the trachea that is starting to narrow down here, and then right here is very, very narrow, so very strictured right here. And then the intrathoracic trachea looks a little bit more normal. So because of the severity of the clinical signs, we said, well, let's do a bronchoscopy first and see a little bit more what's going on. So, and that's what we saw. So we see a little bit of a collapse of the trachea. It's actually difficult to see the blood vessels because I think the mucosa is pretty inflamed right here. And then you can see also, I wasn't sure exactly what that was. I think it's the trachealis muscles that is a little bit irregular like that, but also it could be just simply cartilages that are actually poking inside the lumen of the trachea. So, and as we are advancing the scope a little bit more caudally, then you can see that very narrowed region, which is what we were seeing on the X-rays. So this is what I think is a stricture of the trachea. So just like for Brico, we went ahead and measured for stents. So we can see the trachea right here. That's a measuring catheter. You remember that narrowed region is kind of in that region right here. So that's nasopharynx. And then you can see the esophagus right here. So we calculate for a stent, but the problem is that we didn't have a tracheal stent that would fit that particular kitty. So, but fortunately, we knew of a study that actually looked at tracheal stent in kitties. So there are 3 cats. And in one of those cats, actually, they used a urethral stent to place in the trachea. So we don't place urethral stent for dogs with tracheal collapse, obviously. But for other type of tracheal diseases, then you can use a urethral stent. So, and that's what we did for this particular kitty. So the stent that we used was an 8x80 urethral stent. So that's a quick video of when we're placing that stent. So you can see that we are placing that stent where it needs to be first. Remember that stricture is kind of in that region right here. So we want to make sure that we span that stricture with the tracheal, well, actually urethral stent here. And then we're slowly opening that urethral stent. It's a little bit bizarre to say urethral stent in the trachea, but we can call it tracheal stent. And then I always pull a little bit on those stents when I place them, just to make sure that I'm really opposing the wall of the trachea. So to make sure that the stent is not going to slip backward or forward. And then that's it. So essentially the esophagus, or the larynx, or the caudal aspect, or the proximal aspect of the esophagus, which correspond to the caudal aspect of the larynx, is right here. So we don't want to open the stent further than that. So this is a pretty good placement of a stent, urethral stent, I should say. So this is, again, another fluoroscopic pictures, and this is a thoracic x-ray of the stent. So it looks relatively well placed. And then we also did a quick bronchoscopy right after. And then you remember how narrow that trachea was. And now it's fully open with that tracheal stent. So a little bit of blood, but that's kind of expected to see with the opening of that stricture. So Stoli is doing great. So 1 week, 1 month, 3 month post-op, doing well, playing very well, no dyspnea whatsoever. The occasional coughing, but very, very minimal according to the owner. So she had been sent home for 2 weeks with amoxicillin and a tapering dose of prednisone, but right now she's off prednisone and off antibiotics, and she still is doing very well at home. All right, so let's go down to the preliminary, to the lungs, and then we'll switch gear a little bit. I wanted to show you or present to you a abstract or portion of an abstract that I presented to the veterinary interventional radiology and interventional endourology back in 2021. So at that meeting, I presented a new technique that we developed here in Maryland to sample deep-seated pulmonary masses in dogs and cats. I will only present to you the cat data, but my abstract can be found, I'm sure, online somewhere. So remember Agatha, that 17-year-old female spayed domestic short hair that was presented for weight loss, occasional coughing, chest x-rays were obtained, and then showed that there was a soft tissue density on the left dorsal and caudal aspect of the pulmonary lobe. And then we tried to do a transthoracic ultrasound, and we could not really get to that mass because of the ultrasound air interface. I mean, we do transthoracic ultrasound or thoracic ultrasound quite a bit when we can, and when we can, see the masses associated with the pulmonary parenchyma, we definitely will do a final aspiration. I mean, this is a relatively inexpensive procedure. It's non-invasive, seems to be relatively safe and accurate. And one of the biggest advantages is you can actually see the path of the needle going into the tissue, and you know exactly where you are sampling the tissue. So, but the problem with transthoracic ultrasound is that in some cases, it's actually difficult to see the mass because the ultrasound air interface, and sometimes just because of the girth of the animal, or sometimes animals are obese, and it's actually very difficult to access that mass or actually even see it with the ultrasound. So other things that you can do, or other diagnostic imaging that you can use CT scan, which is definitely the optimal method to look for pulmonary masses, and especially to look for metastatic disease or lymphadenopathy within the chest cavity. So it's definitely the best method to do that. But some of the disadvantages is that it's a little bit expensive, and it does not really provide a real-time visualization of you being able to sample the tissue live if you want. So, and then it becomes very time consuming, it becomes technically difficult to do, and it increases the radiation exposure because you're going to spend a lot of time trying to make that needle go towards that mass. Bronchoscopy is definitely another way to access pulmonary nodules, but most of those pulmonary nodules are actually located very peripherally in the chest cavity. And just because of the sheer size of dogs and cats' airways, the bronchoscope is not going to be able to reach that region. And often those masses are actually located extraluminally, so they're not really within the bronchi. So for you to be able to get, significant sampling from those nodules actually becomes very difficult using a bronchoscope. So that's why we thought that, well, maybe there would be another method to sample those pulmonary nodules. And that's why we came up with maybe doing transthoracic fluoroscopy guided FNA of those deep-seated pulmonary lesions. So the advantage of that technique is that it provides real-time visualization of the needle trajectory sub-Q and also within the thoracic cavity. It decreases because you can really see that needle going live into the mass, it decreases sampling time, the radiation exposure, and you can also assess for very short-term complications. Is there any hemorrhage, or is there any evidence of pneumothorax right after you do the procedure? But the thing that we don't know about, in dogs and cats is that, is it safe to do? And what's the diagnostic accuracy to get when you get those cytologic samples from those masses? So, and these are the questions that we try to answer. So how we do it? Relatively easy. Obviously, dogs and cats are under generalized anesthesia. We often do a CT scan anyway before to look for metastatic disease or lymphadenopathy. So, but after the CT scan, they are placed in the sternal recumbency, and fluoroscopic images are obtained on the DV and lateral. And then once we have located the mass, we shave the chest on the ipsilateral aspect of the chest where the mass is. And then using the laser provided by the Vimago, we delineate kind of the center of the mass on the lateral, and then we use a Sharpie marker to delineate the point of entry of that needle in the chest cavity. And then after that, the fluoroscopy unit is placed back on a DV position. So during the procedure, I asked my anesthetist not to ventilate the patient, but the patient can breathe on its own. And then the syringe needle complex is inserted very perpendicularly to the chest wall. And the path of that needle is monitored under fluoroscopy. As long as there are no complications, we try to do 3 or 4 samples of those soft tissue density. And then we send the samples for cytology, and in some cases also for culture. Post-FNA, again, we can assess for acute hemorrhage or development of pneumothorax using that particular technique. And then all animals are recovered in ICU, and then we look at their breathing pattern as well as their pulse oximetry while in recovery. So for cats, and I'm just going to show you the data for cats. Most of them were relatively old, so some of them middle-aged, but most of them were relatively old. For some reason, they were primarily female cats. And interestingly, most of the lesions were located on the left side, and all the lesions were actually located very dorsally in the chest cavity in cats. The volume of the mass that we were aspirating varied quite a bit, but in average, it were about 3.2 centimeter cube, which to me, the concept of centimeter cube is very difficult. So, but you can think about centimeter cube, or 1 centimeter cube equals to 1 ml. So this is a 3.2 ml average mass in the thoracic cavity. The average skin to mass distance was about 4.2 centimeter, and pleura to mass was about 2.3 centimeter. What was important is that in those cats, there are actually no complication, either short-term or long-term. So no complication whatsoever. And the cytology in cats, 60% of them came back as simply just inflammation, and about 40% came back as carcinoma. So it's just a quick movie of looking at the path of the needle. So you can see the needle that is very perpendicular to the chest cavities, advanced through the sub-Q tissue, ultimately will penetrate the thoracic cavity, and then will go into that mass. And then we aspirate. You can see the plunger that is going back and forth. We repeat that several times. And as long as the animal is doing well and no complication, then we repeat that procedure a few more times. So for Agatha's, her cytology came back, unfortunately, as a carcinoma. and the owner had elected not to pursue any type of chemotherapy or any type of surgery, so just supportive care. But what that study showed is that transthoracic fluoroscopy guided fine needle aspiration actually seems to be very safe. I mean, there was no complications noted in cat. In one dog, there was a complication. I didn't show you the data, but in one dog, there was a complication which was very minor. And there was no relationship between the risk of complication and the length of the tissue or pulmonary tissue traversed by the needle. And there was no relationship between the size of the soft tissue density and the risk for complications. In dogs, the diagnostic accuracy was excellent. So all of them had either carcinoma or lymphoma. And in cats, it seems unfortunately to be, well, I say unfortunately, but give me 1 minute here, maybe a little bit less accurate. And maybe because those nodules are a little bit smaller, so a little bit more difficult to get to. But I'm raising the question that maybe in cats, some of those nodules are actually benign. They maybe just represent some inflammation, maybe some mucus and some inflammation. And in two, because I'm saying that because in two of those cats with the inflammatory changes based on the cytology, two of those cats, one of them lived a year and a half, and the other one lived about 3 years post-FAD. And then when we looked at serially, we look at those X-rays, the nodules didn't increase in size and didn't increase in number either. So I think that in some of those cases or some of those cats, you can have probably some benign nodule, but this is again to be determined. So before I finish, I just want to do a quick thank you to my team. Obviously, I'm not the only one in the interventional radiology room. So I have Dr. Kakar, who is my internal medicine colleague, and then Dr. Keats, who is my surgeon, who is helping me, and then a long list of technicians that are willing to help me during those different type of procedures. So thank you very much, everybody, for coming. I definitely want to thank Epica Animal Health for allowing me to present this talk, fluoroscopy guided interventional radiology in dogs and cats. And I would be more than happy to entertain some questions if there are any.
Thank you, Dr. Jacobs. That was excellent and enlightening, and really enjoyed that.